You are listening to Walking Home from the ICU. We will be exploring how to save and preserve lives in the ICU. All opinions and views shared are unaffiliated with any organization. Today, I want to give a special welcome to the survivors that have been listening with us. I started this podcast with the ICU community in mind, but I overlooked how much of our community our past patients are. They may leave our units, but our units never leave them. I've had an overwhelming number of survivors reach out to share their stories or simply express gratitude for the validation this podcast has offered them. One survivor actually became a nurse, but continues to carry the trauma of her sedation and delirium with her. She says she has found more answers about her cognitive deficits in these episodes than any explanation her neurologist had given her. She didn't feel like she fit the traumatic brain injury mold, but that her cognitive deficits seemed to match up with that of other sedation survivors. So welcome, survivors. Please continue to teach and bring us understanding. We need you. Today we have my colleague, Dr. Schilling, here to share with us some of his insights into the big picture of ICU and even COVID-19 care. Dr. Schilling, thanks for joining us. Can you tell us about your career thus far?
Yeah, so as a background, I did my training in medicine and finished that in 1995 back east at Georgetown, and then did a residency in internal medicine in Colorado, and then a fellowship in pulmonary critical care at the University of Utah. When I left my fellowship, I went into sleep medicine for, probably 10 years, I think. And I still did some critical care, but it was mostly at night on a fill-in basis. I made the decision about 6 years ago to do straight pulmonary clinic plus more ICU and switched over that way. And so I've had the perspective of seeing patients in the clinic for sleep issues and then getting more into their pulmonary issues and the ICU.
And before coming to the Awake and Walking ICU, what was your normal practice for patients on ventilators?
Well, it's interesting. I've seen a lot of different practices. When I was a resident, I saw most patients were paralyzed and sedated. So the ICU is an amazingly quiet place. Lights were dim, nobody was moving, and it wasn't clear to me whether that was good or bad or right or wrong. That's just how it was done. As I moved into fellowship, we still had lots of issues with sedation. We were at least looking, though, at, for example, propofol, and finding that if you left people on propofol straight for 72 hours, that it took them a lot longer to wake up and it prolonged their ICU stay. And what we didn't know is what happened afterwards. In fact, I would say that most of my career, people have not focused on what happens to patients once they get out of the ICU. That's not been the concern. The concern was always to keep them alive and get them out of the ICU. And what happened after that, nobody really knew. It's not that they didn't care. It just wasn't the focus. And fortunately, over time, people did start to look at effects of sedation and trying to really pinpoint who are we sedating? Are we sedating for, or who are we sedating for? So is it patients to minimize trauma and pain, or was it us to make it to eliminate the sense of something happening? So we got to be more specific about what we were actually treating.
So then, when you came to the Awake and Walking ICU, what was that like for you initially?
Well, yeah, I mean, it was certainly different because the approach was very different, where it was much less sedation and working on avoiding delirium. And it was clear to me that delirium was a bad thing. You couldn't talk to people. People didn't seem to do as well. But then as I spent more time here, one thing is a picture's worth 1,000 words. So being on call in the middle of the night and having somebody walk by with 4 staff members, and the patient being on a ventilator, but still walking was fairly dramatic.
Did that scare you at first?
Well, yeah, I mean, I think I was like, oh my gosh, what if they pull their tube out and aren't they on a lot of support? I don't know if we can do this. But with those thoughts, when you see somebody awake, walking and waving to you, while they're walking on all that support, says, well, this looks okay. And I see this a lot and have not seen a lot of adverse events with people walking. And certainly, what I do see is people getting better more quickly. And I think in the long run, being discharged to home from the ICU rather than to a long-term care facility and then hopefully home. And it seems like people's function's better.
Yeah, and we recently had a patient, and I bring this up because I've shown this picture to a lot of people on social media because I had her 100% endorsement. She had severe pneumococcal necrotizing pneumonia and had a really complicated course, including septic shock and alcohol withdrawal, and was delirious. But once that cleared out, she was stronger, more functional, but her lungs got worse. And at one point, we tried to prone her twice, and she actually oxygenated better walking than proned. So she was walking on a PEEP of 18, 100%. We've walked people up to a PEEP of 20, maybe more.
Yeah.
Everyone tolerates it differently, but she was cruising like 600 feet, I think, at a time in those kind of settings. But people have a lot of concerns. A normal mobility protocol will show that you can't even dangle someone, you can't even sit them up until their FiO2 is less than 60, PEEP of 8. Now, there's no real research behind that.
Right.
Yet, there's no research showing how safe it is. So how do you feel as a pulmonologist about patients walking on these higher vent settings that scare people so much?
Well, I mean, it's interesting. I think the focus shouldn't be on what the setting is. The focus should be on whether or not we can deliver enough oxygen. It's all about oxygen delivery and are we ventilating people well? And if you're monitoring, and for the most part, it's going to be your oximetry, but you can check blood gases as well. But if you have someone standing up or walking and their oxygen levels are adequate and it looks like they're getting adequate oxygen delivery, there's nothing that says they shouldn't do an activity. Now, if you stand somebody up and they pass out or their oxygen levels drop into the 50s, okay, well, that's a no-brainer.
Right.
But there's nothing that says it's any safer to prone someone than it is to walk someone. In fact, you might argue that proning someone for 18 hours at a time might be less safe, more of a chance of pulling out the tube, less of a controlled setting. You're not with staff all the time while you're that way. But when you're walking, everybody's on point. All right, you have your respiratory therapists, nurses, you have enough support to get people around the unit. Everybody's looking for something to happen or to go wrong. And that I think makes that activity safer. And from a physiology standpoint, you're trying to get basically ventilation or airflow to the place where the blood flows. And if you're just on your back, you get that it doesn't work as well. You get fluid buildup and other things that make it hard to get air in and hard to get blood in. If you change position, whether it be lying on your stomach or walking around, the dynamics change. Gravity gets to play a role. The diaphragms probably work better because gravity's pulling them down. So I think you buy yourself some advantage. And even if they're on high support, as long as they get enough oxygen, I don't see any reason not to do it. I haven't seen any study that says it's a bad idea. I think there's fear, but we fear the unknown. And my experience has been that this works and is worthwhile.
And now that you are in the clinic and you follow up on our severe ARDS survivors and with almost all of our pulmonology patients.
Yes.
What do you see their outcomes as far as quality of life and even pulmonary function?
Yeah, so it's a little tough. I mean, I haven't done a comparison of patients that walk in the unit versus not walking as far as straight pulmonary function, looking at pulmonary function tests or physiology. What I have seen is that patients that are walking and we use less sedation, they seem to get less delirium. And their recall of the unit of what happened at that time is a little bit more intact. They may have fewer nightmares. They're, and not only that, I mean, more importantly, probably when we do this, people, they come into clinic and they're like, okay, I'm getting around my house, but not only that, they're going back to work. And we had one patient that was incredibly sick on incredibly high settings on his ventilator, and we didn't know if he'd make it, but he did eventually get through. We worked with him, mobility on him, and when he was back to work very quickly, and is still working, brain's intact, and he's fully functional. And I don't think before all this I ever saw anybody in clinic after the ICU, because we didn't even know the importance of sending them there to check in on people, because things can go wrong when you go home. And so I don't think we were looking. Now we are.
And that's so interesting that you say that they have more memories of the ICU, and yet they have less PTSD or less nightmares about it.
Yeah, I would say less PTSD for sure. I mean, it's tough. A critical illness, no matter how hard we work, there's a change in somebody's life, and depression comes in, and sometimes PTSD. But I think it's probably less, and I think it's nice to be able to address those in clinic. And every patient to a T says, part of the reason I walk today or can move is because you didn't leave me in bed.
Wow.
Doing nothing. So they're actually, some of them are like, I can't believe you made me do that, but they are appreciative.
Yeah, not everyone's super excited to do it in the moment.
No, not at all.
But I think they recognize that that's the only reason they walked out of that.
I think that's the case.
But I think we have such a misconception of what causes post-ICU PTSD. So that's interesting that you would see that validated. The research that we have showing that PTSD is caused by mostly from delirium, from hallucinations, from the alternative reality that they experience, and that it's more protective against PTSD to actually be awake, to know what's going on, to have real memories and recall of their ICU experience.
Yeah.
So you've actually seen that. I just read it in research.
No, I think I have. And what's also helpful is to have family that can help fill in the blanks. And so family will come in with people after they're out of the hospital, will come in with their husband or wife, and it works well to have them filling in the blanks when somebody's, I don't remember this or this, I remember that night when the nurse was trying to kill me. And if I say, well, actually what was going on then, and that seems to help, because sometimes you get these blanks, your memory, for whether it's medications we give or just how severe the illness was, your brain doesn't remember, doesn't want to remember. And then your brain tries to fill in blanks. And then often it'll put in very graphic, terrible things that I'm pretty sure didn't happen. And so that family narrative is very helpful as well. We really look at, when we care for people in the ICU, family is an integral part of that.
Yeah, definitely. And ICU diaries, I think for that reason, are so effective, that it fills in those blanks and keeps this timeline straight.
Totally.
And so now in the COVID area, we have, speaking of family, new barriers that make continuing this process difficult.
Yes.
What have you seen as far as how are we taking care of these COVID patients, and what are their outcomes?
Well, I mean, we have tried to do, I think, the same thing we've been doing for years. And again, I didn't create any of this. I just came in, this was shown to me. I think it works. And so it's been easy to adopt. So we do the best we can to not sedate people heavily, even when they're on a lot of oxygen. And there's a special challenge right now because they have a highly contagious virus, and I think we're probably not spending as much time in the room. We have to get on all our gear and all. And so there's more time alone. There's more isolation. Family often can't come in. And I've been amazed with the team working very hard to do essentially video visits or iPad, whatever, with family, so that we can at least get people face-to-face via some sort of device. And I think that helps. I spoke with someone today that was just discharged 5 days ago, and she was in our ICU for about 2 weeks and on a lot of oxygen. And she said, it was easier to get better because the staff was positive and they pushed me. They made me exercise. It was terrible being in a room alone. It really helped me to be in the sun eventually because we moved to a room with a little more sunshine. And she's now back to feeding her horses, trimming her fruit trees, and active. So she made it through. And I think because we pushed her so much to walk and stay engaged, that she's done better than she might have.
Was this one of our patients on the high flow?
Yes, she's on high flow, never intubated, which was great.
And she spent a few days on what settings, like 100%?
She was on 100% for a few days, 50 liters a minute, which is a very high setting. Earlier on in this pandemic, she would have been intubated right away, and maybe that would have been okay, but it was easier for her and probably for us to take care of her when she stayed on high flow.
Yeah, it's exciting to see that not everyone ends up being intubated here
right.
now, and that everything kind of gets better when they're on high flow for all the other aspects of it, but yet some people still need to be on the ventilator.
Absolutely.
And what do you see as far as their outcomes, even those that were on the ventilator?
Well, we've had some excellent outcomes where people, and you've heard from some others that have, I think, been on this podcast, where they were incredibly sick and on the ventilator for a long time, incredibly high settings, and times where we thought they would not make it. They proved us wrong, which was wonderful. So getting on the ventilator is not a death sentence. It may mean that you're going to be in the ICU with us, getting to know us a little bit longer. But we can get you through that. But again, I think it's crucial that we minimize sedation, minimize any, sometimes we'll paralyze people to get them enough oxygen, but if we can minimize that, I think overall people will do better.
And all of our survivors have discharged home, correct?
As far as I know.
It's an awesome track record. We have just tried to stick to what we know. Any other memorable moments throughout your time in this ICU?
Yeah, I mean, I think it's kind of more of the same. Again, I'm always pleased and kind of amazed when I see people walking around on a lot of support, including the ventilator. I love it when people write notes back and say, "Hey, thank you. That was hell, but I recognize that I got better because you guys are a team and you work together and you made this happen." It's an unusual place. So it feels like the people we care for get it and they appreciate our efforts, because we have skin in the game. It's a job, but we really, really celebrate when somebody gets better, and we cry when they die or they get worse, and it affects us. So probably the best thing is watching people get where they need to go, and that's sometimes better, sometimes it may be the end, but doing it together with family and working together is probably the most meaningful thing.
Awesome. Thank you so much, Dr. Schilling, for sharing this with us.
You bet. Thank you.
Appreciate it.
If you want to join in on the conversation, leave a voicemail at 801-784-0472 or reach out to me on Twitter.